I'm just going to jump into my section 2 of the paper. And the section 2 actually requires that I look into a comprehensive review of theoretical and empirical literature. Now, what I did in this section is to look at the human ecology theory as a framework that guides my thinking when it comes to childhood adversity. And I also explored cultural risk theory. These two frameworks really helps me to be able to understand how culture plays a huge role in the perspective of risk and how people perceive risk. So in looking at the human ecology theory, I was able to really see how childhood adversity within the home or even within the community is being influenced by social, cultural, technological diversity of opinion. And using cultural theory of risk, like I said, I was able to see how within different contexts, risk could actually differ or even be the same due to cultural relationships. So in exploring human ecology theory, there are 8 concepts, but within my own paper and my own framework, I used 5 of those concepts. I'm just going to jump into the 5 I used. The system thinking. The system thinking actually sees the human ecology theory as a complex whole that is connected into either things or into facts, which means that a child exists within his own given system, either within a family or within a community. And this family or community exists because there is an environment. And having said that, this family could also interact with each other because there is a channel of communication that helps in this interaction. That comes to the second concept in that framework, which is language, culture, and technology. These are the tools that also helps in interaction within the framework of the child's environment, which includes the social cultural factors and other factors also. When thinking about this, you want to look at the fact that, yeah, there is a structure that should be put in place that helps these interactions to move on. And that is the next step in the concept that looks into how structure, how systems, or even changes in those structural systems plays a huge role when we're talking about a child in its environment. In as much as we know that there are interactions and there are all of the structures, there is a need for boundary within an environment. It talks about irrespective of how we think a child's experience should look like, there should be a boundary as to what extent this experience should actually go so far that will be seen as an adversity. And therefore, the diversity of that environment has to be put in place in order to make a sense of the child's experience. In all of this explanation, the cultural theory of risk helped me to be able to look deeply into how and why people assess risk differently. Since we've been able to establish that there needs to be an interaction within a given environment, and there has to be boundaries. However, in looking at all of this, we still need to recognize that there are different aspects in which individuals or society actually perceive risk. And in that, I'll be looking into 2 major things in which this system, this framework, cultural theory of risk framework actually talks about, which is it helps to develop how risks are both constructed and how people actually, and why some dangers could be politicized or while others could actually dominate while another perspective of risk. In trying to think about all of this, I looked into, in trying to think about all of this, let me just, since I've given a little bit of background because I'm trying to work with time also, I'm just going to go into my empirical study and what I was able to find out from my empirical study. I used Psych info, I use African Wild info, I use PubMed, I use social service abstract in trying to understand what literatures have done when it comes to assessing childhood adversity from year 2013 to 2023, using the framework of ACEs and expanded ACEs. I'm going to go into my cross-national analysis. Okay. I'm going to go into...
Yeah, we have to make it 10 minutes short, so.
Yes. Thank you for this amazing presentation. I think it was very instructive, and it's interesting how you try to narrow down your research to other places and other environments. I do have a comment, and then maybe we can gather all the questions and start the discussion after. We still have the time for the discussion. We have 20 minutes, a little less than 20 minutes. So my question is, how do you consider the history of the country in terms of politics and youth movements to understand the impact of this on childhood adversity? Thank you.
What I did majorly is to go through policy history. And through the policy history, I was able to get the historical context when it comes to the how children even became visible in the society, first of all, before we start seeing adversity among those age groups. And across contexts, before the 19th century, it's been perceived like children were visible across contexts. But however, from Children's Bureau statistics departments in the United States, they were able to start putting in intentional structure in place, like research that got engaged more into children and the well-being of children, and that evolved over the year into CAPTA. CAPTA is actually the law that curbs child abuse within the US, and even recently, it's been moved from the thinking has shifted from trying to curb childhood adversity into prevention, which is the Family First Act that was ignited in 2018. This act majorly looks into prevention of childhood adversity, such as children not going into foster care, children not even entering into the child welfare system at all, because we want to be able to support families with every resources they need not to get to that point. So, but within the Nigeria context, there was actually a law initially that was established during the military regime, and that evolved over time with the Child Rights Act, because the US did not ignite or rectify the Child Rights Act, which is the UN Act that guides many nations on how the right of the child should be protected. But within the Nigeria context, yeah, we were eventually able to ignite that law in the year 2005. But one thing that became so, what will I say, disturbing about the act, even with the fact that it was rectified in Nigeria, was the fact that the government left it for states to domesticate it. And that actually put a lot of northern states into the decision of we don't want, because it contradicts Sharia law, and that is where the culture comes in place. Sharia law basically is like the law that is predominantly Islamic, that that actually encourages a lot of other kind of actions like child marriage and so many more. So due to the fact that the northern part of Nigeria is majorly interested in child marriage, they really don't see anything wrong in it. So it was difficult for them to really domesticate such kind of acts. But however, at this time, at the moment, it's just one state that is yet to domesticate. Even with the fact that most of these northern parts have domesticated the arts, it is still a challenge. Nigeria is still one of the top countries recognized as, engaging in child marriage, according to UNICEF.
Thank you. Are there any questions in the audience?
I noticed that in the examples of adverse childhood experiences that you provided, they seemed on the whole to be like kind of more spectacular forms of violence or exploitation. I think I saw like child trafficking was there and exposure to ritual killings, and these are extraordinary events, I think. And I didn't see on that list as much the more mundane kinds of violence or abuse that children might experience within the home or within families. And I'm curious about that choice. Was that purposeful? Are there other ways to think about that category? Did I just miss things?
Okay, thank you for that question. So when I started, I said I looked at childhood adversity within the concept of ACEs and expanded ACEs. Now, ACEs majorly talks about household events, the framework, while expanded ACEs talks about community and environmental stressors. So I actually jumped into expanded ACEs and how you could see the differences in the expanded ACEs. That was where those illustrations came up. But from my research and from my from diving into literature, I could see that when it comes to ACEs and how it has been operationalized within the US and Nigeria, it's basically the same. And that is the argument that, is there something more that we are not looking into? Why are we using the concepts and the operationalization of the Western in research when it comes to the Nigeria context? Can we do more of the qualitative research to be able to dive deeper into this?
Yeah, I guess one comment I have to that is that culture is such a complex and dynamic and all-encompassing thing that even at the community level, only looking to like these more spectacular forms of violence, to me, it seems like there's more space within culture to think about other like mundane forms of community violence or like ordinary patterns. And I don't even know what those necessarily are. And I don't even agree with some of the ones that come to mind. Like I know historically in Nigeria, like child hawking, like street hawking for girls, I'm thinking of Abasidi George's work, was a big issue to kind of reclaim the rights of the girl child and get girl hawkers off the street. And there's a good argument that culturally it actually made a lot of sense for children to take on apprenticeships and everything like that. So that kind of mundane violence, I don't want to put back into the category of adverse childhood events, but it still seems like there's space there to think about exactly what you're saying about like not imposing the exact same categories because childhood can still look so different because of the politics, because of the history, because of the economy, and especially because of the culture. And I kind of bristle at the idea that it only looks different insofar as like child soldiers or these kinds of, more headline making examples.
Yeah, that is actually one of the things I also addressed in my study, but I couldn't get there. And this is it. Now, when I was looking at the ACEs framework, the only thing that was different, that was divergent when it comes to both contexts is disadvantaged socioeconomic status. And this is an item on the framework. And within the US context, it was actually operationalized as recipients of welfare. But that could not be domesticated in any research in Nigeria because where is the recipient of welfare coming from? There is no systemic structure when it comes to place. Now, that comes back to your question of how people describe risk. Why? Because there is no systemic structure put in place to help and support families. Families are put themselves under the pressure of having to make their children, actually go into street hawking and all of those things. In as much as we see the danger in that perspective, what about the financial support it provides for those families? That is number one. Number two, at what point, that is one of the things, the cultural theory of risk, which was like actually critiqued in my section 3, did not address. To what extent do individual perspective of risk comes together as a synergy to form a social or a societal perspective of risk? Now, individuals did not see that as risk because it helps them to actually support their family. But societally, it is risk because it puts children under so many kind of other risks like child abuse, economic disadvantage, financial exploitation, and all of those other things. However, there is a systemic structure to bridge that gap that exists between individual perspective of risk and group perspective of risk. So at what point do we get there? Yeah.
I have.
Okay, that was very
Oh, I didn't have a question, but I think you answered it. So.
Yeah, Well, I think I have just a comment. I wanted to maybe conceptualize the concept of child marriage in Nigeria based on Islamic law, because I know that Islamic law doesn't really talk about with child marriage. But there's a difference between child marriage and early marriage. So I think early marriage is what Islamic law advises and based on certain reasons. So for northern Nigeria or some many parts of northern Nigeria to be participating in child marriage is a thing of culture, which I think we can try to buttress more of that. So that instead of saying that child marriage is legalized in Islamic law, we are likely not to be seeing their traffic. We just try to look at that.
Oh, okay, well, thank you for bringing up that point, but yeah, because there was an aspect of that law that I saw, and I'm just trying to go back to my study to talk about that much.
Have the same comments regarding that. I think that Islamic.
It's just an Islamic perspective. So Sharia law is a law that is based on Quran and Hadith of Prophet Muhammad. So and a lot of people bastardize Islamic law. So to say that you want to have some kind of personal interest in what Islamic law says, and that happens a lot in northern Nigeria, where people try to say, okay, yeah, this is since northern Nigeria practices dominantly Islam. So whatever many of them do, people think that they're actually doing it based on Islamic law. So it's a quite different thing. We have other places that also go into child marriage without even using religion. But people always try to use religion as a kind of a bait to say that, yeah, we are practicing it based on our law. So, but basically, in Islam, Islamic law doesn't really go in support of child marriage. But people try to say, okay, when you go for early marriage, so you try to do child marriage. That is the conceptualization of some people. Whereas we cannot actually say that it's child marriage based on, yeah, there was a time the former CBN governor of Nigeria had married an 18-year-old lady. And some people say, yeah, it's child marriage. But it's not child. I married at 25. So some people will say, yeah, what you are doing, nobody can actually say that this is the age you marry in Islam. Islam says that if you want to marry, you should have certain things to be put into consideration. Are you capable financially? Are you capable emotionally? Are you capable mentally? Are you even capable physically? So that is the angle I think we can just try to look at. I think we can just talk about maybe early marriage and child marriage. They are two different things. So instead of saying that maybe it's based on Sharia law.
Okay, well, yeah, I actually agree with your point, but it's just that the way it has been conceptualized when it comes to research still shows that there is an aspect of that Sharia law, which I'm trying to find. Is just that this is like my edited version of the paper, because I really put that in my full paper, and because of time page limits, I needed to cut a lot of things off, which actually state that there is an aspect of that law that actually addresses, child marriage. And that was the major conflict when it comes to the integration of Sharia law and the child right law within that context of Nigeria. Yeah.
Well, one question I would ask is, what is actually the difference? Now, I'm asking as somebody who doesn't know. I mean, what's the difference between child marriage and the other one you mentioned?
Early marriage.
Early marriage,
Yeah.
according to Sharia law.
Yeah, it's there's a very wide difference between early marriage and child marriage. Child marriage is when you marry at the definition of child according to what different people know based on culture. Child marriage will be from someone who doesn't have any maturity stage yet. So that is child marriage, which is predominantly in the north. Don't argue with that. But early marriage is when, some people can say that when you marry at 17 or when you marry at 18, that is a child. United States, marriage at 16 is not, you are not marrying a child, but that person is of consent and can say that is what I want. But child marriage in Islam and in many other Nigeria is like when you are married not even according to your own choice. So maybe trying to build you more or less like a forceful marriage. But if someone from 17, I have a daughter, for example, let's say she's 17, she's 18, she's 19, and she decided, okay, I want to marry, and there are certain measurements that we are going to look at. That, okay, are you really capable of marriage? Do you have a husband who is capable financially? Your husband who is capable mentally, who is capable emotionally, and who is even capable physically? Are you even ready for this? So we have people who, in fact, in history, we had people who didn't even, are we even married even before 17? So that doesn't really mean that it's what Sharia law is actually talking about. And it's also similar to arguments of Sharia law being a kind of promoting capital punishment. That's another argument which I don't think we can also have time to really discuss. So my own point is just that we should try to not to conclude that yeah, we can have research, we can have studies, and that is why we should try to look at how reliable, how credible are those studies. We can consult primary tests in that instances, maybe consulting those who are within the religious cycle, who knows different details.
Okay, I think,
Thank you.
Dr. Diop.
Still have 5 minutes left for people who 3 minutes left for people who would like to ask a question for Olawumi. So do you have another question so Olawumi can respond on her presentation?
I would like to hear more about your analysis.
Thank you.
If you could do that in 3 minutes.
Oh, okay. Okay, okay, so I guess like some of the major aspect of the analysis is the fact that within the US context and within the Nigeria context, I noticed that the ACEs framework has been operationalized and defined the same way. But when it comes to the expanded ACEs context, the way it has been defined within the Nigeria context is a little bit different because it's been integrated into the ACEs context. And for me, I feel like research isn't clear in that aspect. So therefore, most of the time, we really have not defined what our community stressors are to actually capture them in research. So another thing is the fact that the instrument that has been used so far in both contexts are majorly retrospective, which means that they capture experiences of childhood, which means that there are so many experiences that people probably do not recall, even while they're sharing their experiences. And while can't we use more of a real-time perspective instrument, whereby we can ask children, what do they see in their own language? How do they feel about these experiences? Then we can capture that more in research to be able to help bring more interventions that are more immediate and support rather than being waited to later life, which actually increases cost really on government spending and all of those things. So another thing is the fact that all the study on it vocally and language they've used quantitative. So from that perspective, I feel like that is why a lot of constructs perhaps have been limited to just those research that have come up over the years. So perhaps if there are more of a qualitative research that can at some point see, are there changes in the way people describe sexual abuse? Are there changes in the way children actually describe physical abuse? Are there changes in the way this category, because my purpose is let us get the things from the mouth of the children on how do you see these experiences? How can you describe these experiences you are going through in your own words? Then we could capture more of children's thing in research, and we could use that to actually come up with a more instrument that can be more contextualized, rather than we using ACEs questionnaire within all contexts, because we feel like that is framework that is. Even ACEs AI, that is the ACEs International Questionnaire, I could actually see that more of the way ACEs been operationalized and measured and defined were actually things that were captured from the ACEs questionnaire, which for me, it still feel like it's a duplicate.
Thank you. Thank you very much for your amazing presentation and your answers. So yes, it's right on time. So now the next presenter is Umar Olansile Ajetunmobi. Your presentation is named Am I Crazy? Communicating Stigma about Jinn-Related Mental Health Conditions in Nigeria. Muslims' lived experience and management strategies. So we are listening to you. Thank you.
Yeah, thank you. Okay, I think that's similar. Yeah, hello everyone. Good morning, good afternoon, good evening, anywhere you are listening to me. So my name is Umar, and I'm trying to present on an ongoing study, which is basically about communication stigma and mental health communication. So basically, this person that we see on the first slide is possessed by a jinn. So, and in the course of the presentation, we are going to see some symptoms of jinn possession. So yeah, in this presentation, I have a long through introduction, the literature review that I have right now, and basically based on the theoretical framework and research questions I want to use, and the research method and the implications of my study. So we've seen that mental health conditions in literature have been over-westernized, in the sense that we have dominant biomedical model that talks about this is, when you talk about mental health issues, it should be clinical, it should be medical, and that's why we have it as over-westernization. And I specifically call it mental health conditions because I want to draw away from the general overview of mental health being an illness, or mental health being a kind of distress. That's why I got it as a condition. Then in literature, we've seen different mental health and stigma communication scholarships that have really talked about learning disability, psychosis, schizophrenia, PTSD, and so on and so forth. And there is still limited studies that really looked out for the number of medical perspective of mental health conditions. We are here relating this to jinn possession. So we've seen it from different, from religious angle, or from communication angle, we've really not got research that really talked about that perspective. And in this study, my focus is to look out for how Muslims living or who have lived with Jinn-related mental health issues, how they manage their stigma, because it's always stigmatized against. So especially for those who are familiar, who know what happens to such a person. And in literature, we've seen different conditions. One is that we should understand what Islam talks about jinn possession and mental health. Is there any relationship between jinn possession and mental health? Yes, we know that jinns are invisible beings, they are supernatural beings that have some kind of power to possess humans. And when they possess humans, they are likely to give them mental unconsciousness, to the extent that within the time frame where when the jinn possesses them, it can be a jinn, it can be more than one jinn, depending on the number of jinns that possesses that person. And there are likely symptoms. We have psychosis, and this is what many people always know about, especially in Nigeria. When you say, okay, you are possessed by a jinn, you always understand that, okay, you have psychosis, you are mad, and that led to that question that, am I really crazy? So we are going to understand that in the course of this discussion. Then it can also lead to hunger when someone has hunger issues. So it's also a symptom of jinn possession, though we can't conclude as a symptom, a symptom, but it can be one of the symptoms. So insomnia, suicidal thoughts, incoherent talks, when someone just continues to have some incoherent talks as he or she's talking, so it can also be likely symptoms. So these are some of the likely symptoms of jinn possession according to Islamic epistemology and ontology. And we also see that when people want to know more about this kind of issue, they try to seek non-biomedical interventions, such as understanding spirituality and religion to cope as a coping mechanism. So that is one of the strategies these people use whenever they have instances of jinn possession. We also see that people with mental health issues, here, Jinn-related mental health issues, they try to disclose at times try to process, that is, they may try to not to reveal their situations based on certain reasons. So one of those reasons is that they can reveal based on culture. At times they can selectively disclose. Maybe someone they trust to keep secret about what is happening to them because it's highly secretive. Some people may the wives of a possessed person may know, the child may know, the father may know, even it might be the community leaders, for example, maybe imam of a mosque, they know that this person is actually possessed based on the needs to do that. Then we can also see that when people try to disclose, studies have shown that it leads to different things. It leads to and leads to divorce, and led to loss of relationship, even social isolation. When people will try to say, okay, yeah, you are possessed, you have that stigma, you have that kind of label, and then we've seen that in literature, and that is what I want to conceptualize my stigma here. We've seen that stigma has different meanings, but basically I'm interested in 3 types of stigma. One is self-stigma, which is internalization of, at least of trying to say, okay, yeah, I have this, internalize that. So I'm also interested in public stigma. But public stigma really starts before someone can have self-stigma. It begins from public stigma. Okay, how do people see gene possession? Then the person will have self-stigma about himself or herself. Then we also have the last one, which is familiar courtesy stigma. In literature, what literature really talks about is courtesy stigma, and that is really talking about relationship stigma, that is associated stigma. So I have, for instance, X has gene-related mental health issue. So the family of that person would be stigmatized based on that person. So it's not really the person feeling that stigma, but those who are really related with that individual. And here I also have stigma attributes. It leads to labeling, stereotype, trying to have, okay, we versus them. Oh, see, this person is not really part of us. And it can also lead to having restricted access to lots of opportunities that really with doesn't allow the person to even be functional part of the society. Also, we've seen in literature that some empirical studies have really talked about what are some of the relationships between stigma and gene possession. One, we've seen that community isolation and expulsion has actually happened. So and this happens most of the time in some Asian countries and even some Middle Eastern countries, the community will try to expel them, or they even try to isolate them from being part of the society. So it can also lead to self-isolation and distancing. When you see someone who has gene possession or gene-related mental health issues, the person will have to self-isolate himself or herself because of that self-stigma he or she has. Then it leads to kind of internalizing fear, shame, loss, and disgrace. That, okay, how will people see me? How will people see my family? So then it can also lead to withdrawal, even no reliance on the family. The family may not even be able to to give that person the expected support he or she needs. We've seen situations like that. Then we can also see where people will say, okay, you are crazy, you're actually mad. So mad or crazy in this sense doesn't mean what people always say, no, as a man to man. So are you mad? Are you crazy? No, we're not talking about that. We're really talking about that level of lunacy. Then I want to drive this study with 2 theoretical frameworks. The first one is stigma management communication, SMC, propounded by Messenbach. And here I won't have much time to talk about it more. But this theory is really talking about is that when someone is stigmatized or mental health issues, one, the person can manage either you accept it or you either avoid that stigma or even you challenge that stigma. So if you can challenge it by yourself, and you even challenge what public have even talked about that stigma. That is why in this quadrant we have accept, meaning that some people will accept the public understanding of the stigma. At the same time, they are going to accept how it is related to them. Then the other part is accept challenge. They are going to accept it by themselves. Then they accept what the public says about the stigma, but they are going to challenge the stigma that it doesn't apply to me. Then the third quadrant is that they are going to challenge and accept, meaning that they challenge public understanding of the stigma, but they are going to accept that conceptualization that's coming from their mind. Then the last one is challenge. They are going to challenge people. Yeah, I don't have it. Then you don't really say that I have it. So all these are management strategies people use to manage their stigma as related to any form of mental health. But here, I want to conceptualize it within the gene-related mental health issues. Then the second model I want to use is just a simple model by Smith. And this is like a process of stigma. For people to be stigmatized, it passes through certain processes. One, there will be message choices people will use. Yeah, you are this, you are mad, you are crazy. So genes is with you. So if someone starts to misbehave, you say you keep quiet too much, or you are talkative, you say, yeah, something has really happened to you. So this person has started. So that is the first stage. Then it leads to reactions. The person may react, having maybe a kind of hunger, a kind of fear, a kind of low self-esteem. Then that will be managed. What are the management effects of the message that the person is reacting to? So this will be the driving forces of this study. And this evidence from literature at the same time with the theoretical model warrants me to formulate these 3 research questions. The first one is just trying to, okay, let me just listen to you. So how do you conceptualize stigma about your mental health issues? So we are going to see, definitely we are going to see self-stigma, we are going to see public stigma, we are going to see the familiar collective stigma too. The second research question will be, in literature, we've seen that there are certain beliefs, attitudes, and actions that Muslims with mental health issues also say, yeah, this is from God, this is punishment from God. So are we saying that religion has some roles to play in stigmatizing beliefs, attitudes, and actions towards their own condition? The last part is I'm really interested in knowing how do they really manage their stigma? Are they really in consonance with what literature has said, or do we also have other ways that we see, or we can see that it manages stigma? For instance, the theory by Messenberg didn't even talk about religion and spirituality as coping mechanisms. So we are likely to see maybe a way of trying to maybe talk more about the non-biomedical perspective of mental health, not conceptualized by Messenberg theory.
Thank you. Thank you. We have to stop now and open the discussion. Thank you for this very interesting presentation. So I think it was very instructive, very interesting how you approached the topic of indigenous psychology and gender-related mental health questions. And I was interested in how you approach the medical professionals about this question in a psychiatric setting. Did you have a conversation with people working in mental health setting who were trained to psychiatry, classic psychiatry, how they reacted to this, please? And apart from my question, are there any other questions that we can take before starting discussion?
If I can, I don't know if you can see us with yeah, you can see. I'm just interested to know very briefly how much of the issue is do you think is mental health, stigma about mental health, not necessarily Jinn specific, and then how much of the stigma is related to the fact that the condition people related to Jinn-related causes. And there it can be 2 different things. You can either believe that that is the cause, and there are certain stigma that come about because of that, or you can believe that this is not a real thing, and you stigmatize the person because they're engaging in what you might think is a superstitious kind of thing. So that's the question, is how to separate out the different kinds of stigma.
Yeah, thank you for these 2 questions. It's because I don't have enough time. I wanted to even talk about that. Yeah, the first question is that how I want to even try to differentiate between from the mental health perspective, from the clinical side and the non-clinical side. So I know, at least when I started this presentation, I said my argument is really about Western perspective. And this perspective is, in Islam, for instance, we have someone who we call Arabi. Arabi is an Islamic exorcist. So if someone is possessed or someone has some kind of strange behavior, so there are symptoms that, okay, this is likely to be jinn possession. So the Islamic exorcist or someone who knows about Islamic exorcism will not conclude yet that, okay, this is actually jinn. We've seen situations like that. There was a young lady less than 21, 2022 or so. She has certain kinds of behavior, and we say, okay, this is likely to be some kind of maybe jinn possession based on the symptoms that we have seen. But when the Islamic exorcist perform what is called arupia, that is exorcism, the person didn't see any action of jinn, because when someone is possessed by jinn, there will be certain behavior, certain certain paralinguistic shows that the person will really display. And the next thing the person said was that Is this person need to go to a clinic to diagnose for maybe the likely cause. At the end of the day, it was seen that she had some kind of trauma. So in that sense is that for someone who is a professional Islamic exorcist, he or she will not conclude that this case is actually jinn possession. So based on the test the person performs, that is the next thing that, okay, this is not jinn possession or this is jinn possession. If this is jinn possession, no clinical diagnosis will ever recognize that cause, that jinn is present there. So it is now the Islamic studies that will talk about that. So in this context, I think I'm not really talking about the medical part. If it is medical, definitely it's not the scope of this study. So the under the criteria of selecting the participant, I have it in my slide. One of it is that the person would identify himself or herself to have been possessed, or through the network, or even the exorcist will say, this person is possessed, actually. So that is to answer that question. It's just that the exorcist will be more or less at the time that this is what we have found out, and the person actually knows that I'm possessed. If you have seen possessed situations where someone is possessed, you actually know that it's actually not medical most of the time. So we are not concluding based on I have it. Someone will say I have it, but he doesn't have it. So Islamic exorcist will be one of the deciding factors of whether this person has exorcism jinn possession or not. Or that person believes himself or herself that, okay, I passed through exorcism jinn possession before, based on the therapy I've gone through. Because UPI is like an example of a therapy. So that's not really medical in this sense.
I think another way to approach the question which Glenn asked us to think about this social phenomena of stigma.
Yeah.
Is this something which is happening as a function of, because the way you framed your research is, as mental health being a natural thing already there. And I'm interested in whether this concept of mental health is because of engagement with modern ways of being. So whether jinn possession is like a normal thing, you might be possessed, that might be a person might be possessed. But does it become a stigma when people start thinking about it as an atypical thing which is causing problems? And I think that's one way to think about it. Like, is your study is the concept of mental health and how it relates to jinn possession, or is it the jinn possession in itself which is producing a stigma, and whether that stigma relates to this psychologization and pathologization of other ways of being?
Thank you for that question. So the concept of the stigma here is that we know, at least from the Islamic epistemology and ontology, but reality of things. Really, we know that some people don't even believe in the existence of jinns. So we know that. That is why I talked about the ontology and epistemology part based on Islamic perspective. Now, Islam believes that jinns are present everywhere. So they may be present here, we don't see them. So it's a power that we cannot even have access to. But they have power over some people based on the will of God, that, okay, if they possess this person, that is how it has been destined that they are going to happen. And when this happens, the person may not, even those who are close to that person may not even know that this person is possessed, since you don't believe that. So anybody who believes that, okay, this is likely to be some signs. So that's there when the person will now walk around that. And when that happens, the person may, for instance, when possession happens, the person may be speaking coherently. So maybe when you have gatherings, the person may be shouting, maybe having anger issues, they have even kind of, even at times can even lead to taciturnity, an ability of a child not to even talk. The person that has been talking before, then all of a sudden the person stops talking. So it may be as a result of jinn possession. But when that happens, the people around who understand that this is likely to be jinn, they have processed that stigma, that issue based on what the society believes about jinn possession. So now from there they will transfer the belief into that person, trying to withdraw from that person. Oh, this person is not supposed to be moved close to, because it's also believed, wrongly, that when you move close to someone who is possessed, you are also likely to be possessed. So when that happens, people will now start withdrawing from that person. One way or the other, the person may even develop other medical issues that is not even outside jinn possession.
I think what would make this research methodology interesting is if you collect two types of data sets, one in like a social setting where that stigma is mental health phenomena, and another, and I would hypothesize in a less modern setting, less Western modernized setting, where Jinn possession would not be a stigma, but rather a normal way of being, not as a mental health issue, but rather something which is ontologically normal and which is supposed to happen. That way you might be able to compare.
That's it.
I'll add to that and say the explanation you gave here of someone withdrawing for a person as a way to prevent the transfer of the Jinn is quite different than other kinds of stigma within your own model. It's quite possible to imagine that Jinn as not pathological, as not aberrant, or, you know, all like, but also still take precautions to protect an individual. And so it seems like there's a really fruitful possibility there to separate the Jinn from a mental health model. Like the stigma of mental health is like established, and that's maybe a separate question, but like peeling apart behavior that's appropriate around Jinns might not be captured by stigma, even though from like a less knowledgeable eye, the withdrawal might look like it's stigmatization, but it's actually just a normal way of, you know, being fair to that person and to the community. So it seems like you gave us you broke down stigma a lot, but I'm not even persuaded that stigma itself captures what's going on in the case that you're presenting.
Should I start now? Should I start now?
Want? I don't know.
Noted.
Questions with methods. So you have conducted interviews.
No, it's just,
No.
it's a work in progress.
Okay. Do you have an idea then about how you will find people to participate, and especially, you know, about online, like what's your thinking there with the online data collection?
Yeah, that's a good question. Having access to participants. Yeah, I have Islamic resources I can consult. So some people have started showing interest already, because I know people, one way or the other, have issues past who have lived with Jinn-related experiences, so that they are ready to participate in the study. So, and in fact, in the eligibility criteria, these are what we have, and some of them will say, yeah, they are ready to let their voices be heard. Though, you know, anonymity also of the thing will be protected. But having access to participants is not a problem. And regarding the online, I have two options to use. One, so to collect data physically. So second one is to collect data online. Some of them are conversant with online technologies and they're ready to give their responses, while some may not even have access to technology. So I'm ready to combine the two together.
So on that idea of recruitment for your data set, like you have your few community samples already, you know, people that are willing to discuss their experiences, but with sensitive issues like mental health, how do you plan to recruit more participants in your survey? How do you plan to be sensitive to their vulnerabilities as, you know, Jinn possession or Western medical, you know, diagnoses? So they should be in a compromised state, right? If they're possessed by Jinn or if they have a mental aspects of that.
Yeah, it is believed that when someone is possessed, like when I was explaining the possession, it's not something that is like the Western way of mental health. It's not when someone has schizophrenia, for instance, or autism, for instance. We know that the symptoms may be constant, but Jinn possession it's not a constant thing. So at times, it may not even know that this person you are speaking to has issues with Jinn possession. So at that time of data collection, the vulnerability may not be there. Okay. Most of the time, two participants I'm interested in. One, someone who has lived with experiences of Jinn possession. I just believe that when you live that, definitely you, after Ukria and after other therapies, you are not likely to be repossessed. More likely, but we are not really guaranteeing that, but not more likely. So why the other part is those who are living currently, but those ones I'm not really focusing on them, because vulnerability, like you said, can really come in because of interviews. So the stuff can begin. But if that happens, I'm proposing to maybe have Islamic resources in my presence. If the person actually says that this is in possession and that's been kind of a consent to participate in the study. In as well at that stage, there is no case of possession. Because I'm calling things, not to go to just happen.
All right, We still have 5 minutes left. So if someone has a question or a comment.
The
You're welcome.
question, do you take into consideration other variables as social class, education, regarding Jinn position?
Yeah, that is very, very important question. So right now, I'm not really thinking about that because I know that in terms of class, education, among the rich, for instance, we've seen situations like that maybe children of the rich are possessed, but it's tried to not to disclose that to the public. Or even within, some of them are not even believe in that possession. So I maybe because of that gathering, anybody who's interested in participating, regardless of whether you are educated or uneducated, whether you are low class or middle class or high class, that really concerns me stuff. So that may not relax because of the discussion, because of the evaluation.
One question about recruitments, if you have, you're looking for people who experience some kind of stigma, or you're interested in their experience of exclusion or their experience of marginalization, but maybe those people are not going to volunteer as readily. So the sample that you have may be a sample that doesn't experience very much of this. I wonder if you've thought about how that will impact your conclusion.
Yeah, as part of my eligibility criteria is that you would have experienced it. So if you have not experienced it, it should be excluded from analysis, because we are not really going to get data from you that actually talks about Jinn possession. So one is that you should have lived with it, then you accept that you have lived with it, and you are ready to maybe share your experience. Then two is that maybe through my network sampling that I want to use, is that okay? Yeah, I have someone who has passed through this before, and I communicate with them. Are you ready to participate in the study? So definitely they must have lived with the experience of Jinn possession before, based on their own conceptualization of mental health conditions and stigma.
All right, thank you. Thank you for your responses, answers, and for the comments. So thank you very much. Good luck for this hard work. We are gonna go to the next presentation, who is Analysis Wana from South Africa, Complexities of Mental Health and African Healing Practices among Amagirha Kwakoza in the Eastern Cape towards an integrative model of in clinical practice. You have 10 minutes.
Hello, can everyone hear me?
Yes, we can hear you.
Is the screen sharing?
Yes, screen sharing.
Okay, all right. My name is Anele Siswana, and I am going to be taking you through this presentation. I'm just wanting to slideshow around the work that I do. It's still in the very early conception stages, and I look forward to your feedback and insights. So I am a clinical psychologist by profession, trained in South Africa, and I'm on a journey of understanding and making sense of the work that I do. So in terms of my positionality, I am a typically known traditional healer. In South Africa, there are different forms and variations of what healers are, but I'm setting the tone so that people have an understanding of the kind of who I bring to this study that I'm working around. and also what I'm trying to make sense of as a healer who happens to also be a psychologist. And so you can see on the first picture, that's how I usually dress as a healer. And on the other side, that's the work that I do as a psychologist who happens to be a healer. In terms of introduction, because of time, I think I won't dwell much on the background, but it's just to give an understanding that in South Africa, traditional healing is quite a broad range area of practice. There are different ways in which people understand it. And for some of us who have had to respond to this calling, there's been a great part of significant illness over the years, over time, which then calls one to a recognition of a deeper spiritual process that one has to undergo. And that process is firmly grounded on African epistemology and understanding of African cosmology, God, ancestors, and nature. And so when one gets this form of calling, you then have to undergo a process where you get trained to be a professional healer or to be trained to be one who would then be able to do the work of divinity. In South Africa, research indicates that about 80% of the Black South African population, people consult traditional healers before they even consider a Western health professional. And a report, according to the Health Professions Council of South Africa, also suggests and indicate that there's a strong need of people who go to traditional healers for various reasons. I mean, psychotherapy in South Africa is quite expensive. And so traditional local healers with divine powers, at the same time with healing powers, these are often people that the majority of the South African population would consult for the kind of healing that they need. And so there's so much work that has been done in this work. And ideally, the understanding is to suggest that in South Africa, literature is there that supports the kind of work that is being done by traditional healers. My problem statement is the area of the role of traditional healers and divine healers in mental health is gaining attention in academia and in medical communities. At the same time, there's a number of studies that have explored this construct and that there's a knowledge gap in the context of mental health and how to work around the integration of traditional healers in the kind of work that we do, particularly on mental health. So there's a need for full recognition around the work of building and bringing these two worlds, the African world, which meets the scientific psychological world. And ideally, the significance of the study is to offer a nuanced knowledge understanding around indigenous knowledge systems and diagnostic and therapeutic tools to engage with what mental health is and possible ways of treating these. And ideally, the overall essence of the study is to contribute meaningfully towards efforts of redefining the discipline of psychology in Africa, particularly in South Africa. The objectives of the study is to explore and elucidate the narratives and complexities surrounding the roles of traditional healers with the CASC community. At the same time, is to examine cultural, spiritual, and practical dimensions of these healing practices. And so my theoretical lenses that I'm thinking around exploring is indigenous knowledge systems. I intend to locate the study from an indigenous knowledge system perspective. I believe in us trying to make sense of indigenous knowledge realities. We need a framework that will hold space and locate for that. I'm looking at exploring at intersectionality as one of the location points of making sense around the study, as well as transpersonal psychology as a theoretical lens because of the strong spiritual element around it. And the research question that I have is, what are the narratives and complexities of a matriarchal around mental health and African spiritual healing practices. At the same time, how do healers, amagqirha, make sense of their role in mental health care contexts within the context of IKS? Research design, I'm thinking of using ethnography. I think it fits best the nature of this study. Ideally is to use own voices and avoid misrepresentation of these healers, because these healers are constructed as uneducated people who are not scientifically trained. And ideally, I believe this method would hold space for that. In terms of the context and sampling, I would draw these participants in the Eastern Cape around areas where predominantly there are a lot of healers around these spaces. I'm planning to recruit 20 to 25 adult participants to identify as amagqirha, that is as healers, minimum of 18 years and above. They should identify as Black, African, especially specific falling under the racial category of being Black. I would look at various stages of initiation and how people have completed this phase, and the exclusion criteria would be herbalists and people who are not trained as healers. Then data gathering approaches will then be face-to-face interviews, which will take in the Eastern Cape, and these will be done in isiXhosa and translated into English. And I would use web-based interviews will be used as an alternative if participants are not in the same location or due to logistical issues. I'll also use spaces as well, such as social media, data analysis. I would utilize stages of narrative analysis as formulated by Murray, and it stipulates the kind of levels that need to be considered when one does this kind of work when trying to do analysis. In terms of trustworthiness, I would contextualize dependability, transferability, credibility, and confirmability around the nature of what fits with the study. And a big part for me would be around reflexivity, around my personal experiences as a researcher who is an insider researcher with the knowledge and understanding as a healer who practices in this way and the manner. Also, as a clinician who's a psychologist at the same time, around processes that would then unfold and epistemological reflexivity around the process. And I think these are the ways of how I would hold integrity in trying to maintain the trustworthiness of this study. And obviously, looking at ethics, I will look at various ethical issues. But one of the things that is quite key and prominent in the kind of work that you do with kind of healers, the question that comes in is, how do you maintain space for secrecy, space for sacredness, and space for making sure that the deep narratives of these healers are protected at the same time, that nuances of the actual processes of being a healer are not exposed, but looking at some elements of that. So those are some of the major ethical aspects that I would look at, and obviously all the other ethical elements that are important in a study would be observed. And I'll stop there. Thank you.
Thank you. Thank you so much. I think it was, it will be very interesting research. I think it's very interesting your double positioning as a traditional healer and a clinical psychologist. I wonder about the registry. I'm not sure the word is well chosen, but the registry where you analyze the content of what people say, directory, is that the right word? Where you just find the meanings and symbolisms of everything you hear from your clients in every direction, whereas it's clients from the traditional healing practices or the clients from the clinical psychologist. how do you make the interference between the two fields, or is that the same field in reality?
Yeah, certainly these are two different fields, and obviously psychology is located within the Western Eurocentric construct as we know it to be. And in that way, I always make sure that I maintain the professional integrity of what that space is and what it requires and the ethics that govern it. And in South Africa, the Health Professions Council of South Africa has clear guidelines around what is expected and what is not expected. At the same time, in the world of traditional healing or divinity, there's also its own codes and its own way of engaging with it. So I treat this world as mutually exclusive, even though at some point there are certain assimilations that work. So how I work, I'm a clinical psychologist, and I'll do clinical assessment and everything a clinical psychologist does. But it's only when I cannot silence my being and my positionality and identities that then play out in the room. And obviously, if I see something from an intuitive perspective, I have a way of channeling it differently in a clinical context. So to respond to your question, I treat these as mutually exclusive, but I personally believe there's mutual benefits from both ends.
Thank you. Other questions?
I'll ask a question. I really appreciated the kind of scales that you brought to this discussion of like the very specific regional and cultural scale of the group that you'll be working with, but then also claims to like the insights that provides to an African approach, and then a kind of global indigenous model of what it means to look at these knowledge systems. And I was wondering if you could say a little bit more about how those scales relate to each other, how you're moving it into an argument about African belief systems or African practices, or a kind of broader global indigenous one. What does it mean to you, or how are you going to empirically make these inferences from one scale to the next?
Yeah, it's a very complex one. Hence, I even titled the working title as complexities, because there are many layers into this, and obviously there's the strong debate around decoloniality, decolonization, indigenous knowledge systems. Ideally, it is to assert the understanding that most of these traditional healing practices and modalities, the science world constructs it as an unscientific way or as an unscientific tool. So at a scale level, for me, the kind of work that I do, at the core of it is to assert that African knowledges, and there's so much that we can gain from African practices that inform the way we engage with clinical diagnosis, the way we engage with clinical treatment modalities. For me, the fact that what is deemed as African is not scientifically in a journal article, it does not discredit it as knowledge system in its own. So this work theoretically positions African psychology or African situated psychology as a science on its own, which helps its own people to engage with it. Also, at the same time, teaching the scientific world that the fact that this is your understanding, it does not mean these knowledges are disqualified. So I think decoloniality, Afrocentricity would offer space to hold grounds for a solid argument around these intersections and scalings that you are mentioning. I hope it helps a bit for now.
Please, Glenn.
Sure. Your question, or your response to the question, sorry, your answer about whether or not these practices constitute science. So is it important for you to think of them as science as opposed to some other kind of knowledge system? What is your conception of science such that this is or is not science? So one can legitimize them. Another way of asking the question is to say that one can legitimize the practices by referring to them as science, but maybe there's some baggage that comes with that. One might legitimize them by some other means that not only challenges their pathologization or delegitimization, but also challenges the need to cloak it in science. I wonder how you think about that.
All right. It's a great thinking, and there's so much work that has been written about that by Professor Baloy and many other African scholars. I think my struggle is how the Western world looks down or looks on African knowledges and deem them by virtue of them not being scientifically proven is in science. But for me, local indigenous knowledge systems are everyday sciences, if we can use that in inverted code. It's a science on its own. So if it's a science on its own, it means people who believe in it, people who practice it, who are custodians of the living experience, they would understand it as a knowledge system that is deemed as scientific in their own view. But it's ideally the word science for me, and I agree with your argument, it may lean more to an idea of a quantitative approach because this is a qualitative study. So I think maybe something to think about, is it okay to locate it as a science or to treat it as a local knowledge that exists on its own as legit. And the other keyword for me that comes into mind that you've mentioned is legitimacy. However, for it to be legitimate, it has to be deconstructed for the science world, or psychology in this case, because psychology is a dominant form of knowledge systems, and it disregards other knowledges that are not considered as science in the way of how it understands it. So for me, local knowledges in their own right are legitimate, but psychology doesn't see it in that way. Yes.
Thank you for the explanation. You said psychology is a dominant field that kind of excludes other. Well, in my part of the world is exactly the opposite. The dominant field is indigenous beliefs, and psychology is something that's kind of trying to make its way in people's minds. So the way we see it here in West Africa is that we consider psychology like the strict meaning of what the word means, for example, and a discipline that tries to understand and describe and analyze what goes on in the mind. And if we take this definition, we try to englobe everything that goes on in the mind, including everything that indigenous psychology targets. So in certain ways, it doesn't really exclude, it actually finds a definition that makes sense in people's definition of psychology. So the word psychology is a word that we speak in like French, English, and whatever language we use in the country where we are, but it means the definition of what people think about in the country where we are. So, I mean, that's the way here in West Africa, it's being taught and seen. And I mean, so.
Well, for me, where I stand in South Africa and what I've observed, it relates to the first speaker, the second speaker, around conceptions of mental health or conceptions of illness or psychopathology and how it's constructed in local languages or local knowledges. But from the way it stands and the big movement in South Africa around decoloniality, decolonization, and Africanization of psychology, we are in search of a true meaning that makes sense of our lived experiences around psychology. But the current framework and theories do not hold space for the realities of our people. Like if I work with the DSM and I have someone who is presenting with ancestral calling, which you would see more of a psychotic presentation or some kind of a schizophrenic presentation. Whereas for me as an African healer, that is a sign that does not suggest pathology. There may be elements of pathology in it, but from a perspective of where I work as an indigenous healer, there are some parts of it that are not pathology. So some of the tools and what we use for diagnosis, for example, and the psychological tests that we use do not speak to the experiences of a typical poor Black person in the township, in the rural areas, who is in search of the psychological services. And so whatever findings and whatever that, and there's a strong historical, political history in South Africa of how psychology as a colonized and as a subject that is used in science to speak against Black bodies. So we are very careful about these simulations, but at the moment, the big movement is around looking at a kind of psychology that speaks to what it means to be in Africa and practicing psychology in Africa.
Thank you. Thank you. Are there other questions for the speaker?
I have a comment. So first, thank you for sharing your project. It's very fascinating. You said that the goal of the project, as I remember, I'm paraphrasing that, the first goal is to produce a local knowledge system, a sort of an indigenous way to produce a body of knowledge, a cosmology of healing. And the
Yes.
second aspect you said was lessons for general clinical practice. And I'm wondering, what are some of the lessons do you anticipate, or the different possibilities for general clinical practice? Let's say somebody in Ireland who is themselves white and all of their clinical patients are white. How do you anticipate an indigenous knowledge system, which is fine in its own right because it works, like you said, for Black South Africans in South Africa, but what are the lessons, let's say somebody in, with dominant clinical psychology is being practiced?
Yeah, it's a very tricky one. I haven't really thought of it in that way. I'll be honest, because in my mind, as much as when you think of a doctorate, you think of a global or international community. But where my hope is that it will just be a tool for inciting conversations and possibilities of how to use local knowledges and local practices to inform our clinical work. That's the least that I can come to, is finding value in using what is local, what has been historically significant in that population, whether white or Black, but use it as a tool of engaging with mental health complexities, and then finding a way of how those same communities and spaces can integrate those into the way of how they do psychology or practice psychology.
Thank you. You have 5 minutes. Is there another question?
Okay, I don't know if this is a comment or a question. Anele, thank you very much for your presentation. I can confirm that at the University of KwaZulu-Natal in Durban, there's a Sangoma in the Student Union building. Okay. For me, when I got over there and I found out that, I thought that was a level of acceptance of traditional healers in Zululand. So I was gonna ask you, I mean, in a university, a scientific environment like that, I was gonna ask you if there's anything like that anywhere in the world of the courses, if there's anything like that in the Eastern Cape.
Okay, yeah, I think, thanks for your question. Well, as you've mentioned, I'm referring to the literature review that this is not a new phenomenon at UKZN. They have a student counselor and a traditional healer on campus, because the presentations that they deal with there go far beyond our understanding of clinical diagnosis and its etiologies. And chances are one's mental health presentation could be as a result of ancestors are not pleased with you, or could be ancestral calling. There could be a divine kind of thing which transcends the ordinary of how a clinician will do with that. But interestingly, next week, I'll be in Rwanda with 3 universities in Kigali who are wanting to explore how to universally think around African psychology and think about African practices in different student counselings. So I think this is a way of normalizing and thinking broadly of how do we think beyond what psychology offers and use what is local. But the most important thing for me here that needs to be done carefully is this integration to be done with healers, and also our work as clinicians is to empower these healers with all the knowledge that they, for them to be able to engage with what mental health is, what a diagnosis is, just more of as a GP who sees these things, and for in-depth clinical intervention, refer. So there's a strong element of my study potentially wanting to capacitate and empower local traditional healers with basic mental health literacy that will help them to be able to understand a clinical presentation as opposed to a divine or a spiritual presentation. But to your point, there's so much work that is being done in universities. UCT is one of them. Last year, they did a launch where they have indigenous healers as part of a team that works with student counseling.
Can I go ahead?
Yes.
Yeah.
Very, very interesting. Congratulations for the hard work. And I mean, congratulations to all. Thank you so much. It was a great panel. Good luck for the work you have to do. It's the end of the session. So